I'm sure you'll want to ask some of the
Yes? I'm on? Great. I'm not very good at standing still. So when I thought about coming over to Canada, I did actually check the website. You've got a fabulous website on weather. And it did actually promise that the average daily temperature in February was 0 to something, and I thought, that's okay. I'm from Queensland, and at the moment it's 30 to 35 degrees Celsius. So I'm experiencing a rapid temperature drop while I've been here. I did go to McMaster yesterday and it was snowing, and somebody told me today that it can't be that cold because apparently when it gets really cold, it doesn't snow. Oh, thank God it was snowing. So what I want to talk to you today is about a palliative approach toolkit. I have been working with Mary Lou on her project, and she has talked, if you've been in the room, about some of the things that we've been doing together as part of this. So this kind. Yep. Oh, you click on the back, do you? Oh, there you go. Must have clicked on both. So what I want to do, so this is my reality. This is my snowman on the beach. That's what we build snowmen out of, sand. So what I want to talk about is some definitions, and we've heard some definitions today. Why do long-term care facilities need something like a toolkit? And Mary Lou's talked to you about their toolkit. Some history about what we did. A framework that underpins that toolkit. I'm going to walk you through the individual components of it because they're all available free for download off our website. And then I'm going to say what you might want to take from that that might be useful for you here in Ontario. So for us in Australia, we talk about a palliative approach, which is really an approach that improves the quality of life of individuals and their families. And really it's about prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain. So it's not unlike the definition of palliative care. We're talking about specialised palliative care, so that's our services in Australia, and here you have the hospice or palliative care teams. And they're people obviously that have a high level of training, usually work in the hospital or inpatient hospice or palliative care setting. But you have to remember that it doesn't replace a palliative approach, but that we should be working synergistically between long-term care and palliative care services to get the best of them. And then what we call end-of-life care or terminal care. So in the UK now, they talk about end-of-life care strategy, and that's like the big strategy, like for people that live for maybe 2 or 3 years. And so there is a little bit of confusion, but when I'm talking about end-of-life care in the context of this presentation, I'm talking about terminal care. So that's the last days or weeks of life. So the toolkit's an integrated framework of care that relies on 3 key processes, and I'll tell you what those are in the next few slides, using evidence-based clinical tools to deliver best practice in long-term care. So why would we need that? Why do we need a framework? Why do we need evidence-based tools? And if you've been in any of the palliative care sessions, you'll probably recognise that you have similar statistics to we have in Australia, in that most people that come into long-term care die in long-term care. We have a large number of people with a diagnosis of dementia. There's many more that don't have a diagnosis that have cognitive impairment. And 38% of our residents in Australia stay less than 1 year. So you do have to get things organised in a short period of time. So a brief history of the toolkit. It was a primary outcome from a knowledge translation project, which has got a terrible name. We called it the SEBERAC project for short. And what that project did, we had 9 facilities across Australia, which is probably like crossing Ontario, involved in this, and they tested the evidence-based tools for us and the model. And we found that using the bits of the kit and the framework improved advanced care planning, improved the coordination of care by case conferences, improved in terminal care by using an end-of-life care plan, they had better symptom assessment and management. It also increased staff knowledge and confidence in providing palliative care, and the family were far more satisfied with the care that was being provided. So this is our framework of care, and there's been some talk today about prognosis, and it is, look, it's woolly, it is difficult. But I've worked in long-term care for many years, and one of the things that I always came across as a barrier when I was trying to tell people about palliative care was that they never knew when to start and when to stop and what you should do when and whatever. So we came up with these 3 trajectories which are imaginatively named A, B and C. So there's an expected prognosis of greater than 6 months, and it is a you know, as I said, not an exact science, but clinicians who actually know their residents really well actually get this right most of the time. You'd be surprised how accurate this sort of thing is. For those people, we say you should have an annual lead case conference, which includes advanced care planning. So that's for everybody that comes in, and there's been some talk today about you certainly don't do it the day they come in, but probably within the first couple of weeks or a month that you should do that. And then for us, we review that every 6 months. For those people who then get a prognosis of less than 6 months, they go into this palliative phase, we call it, where the main focus of that palliative phase is to have a palliative care case conference, which again includes reviewing people's advanced care plans or advanced directives. It also means that you look closely at some of the common symptoms that people have at this time, things like pain, shortness of breath, nutrition, hydration issues. And for those people, because you've identified that they might only live for 6 months, and one of the main predictors that we ask people to think about that is the surprise question. So would you be surprised if this person died in the next 6 months? We also get them to think about, have they had frequent admissions to hospitals? Have they had falls? Have they had UTIs? Have they had chest infections? So it is a process of sort of putting the picture together. For those people, we say that you should review them every month to make sure that the plan of care that was set at the case conference is being carried out. And when they have a prognosis then of less than a week, and there are some markers for that, then we would start somebody on an end-of-life care plan, and we have one in Australia that was specifically designed and tested in residential aged care facilities, which is shown to be quite effective in improving the terminal care for people. So does that make sense to people? Yep. So as I said, it's not an exact science. We didn't put the PPS on it, although Sharon Castellana has done some work with that for the case conferences. I think that's some of the work that Sharon and I are going to be trying to do is to come up and what is a really good prognostic tool for this setting, and how can we perhaps tighten this up, and when do you fall into those different trajectories. So the evidence behind the toolkit, so it is evidence-based. In Australia, in about 2006, we had these guidelines for a residential aged care palliative approach that were developed, and I was part of the team to develop those. We also have the Australian Pain Society guidelines, and then we have something called therapeutic guidelines, which is sort of the medical bible of all the symptom and drug things in Australia. So they're the 3 things that form the backdrop of what you do in those trajectories and the symptom management that we suggest. So the components of the toolkit, there's many of them. It's taken about 3 years to develop. We had some original toolkit things, and then we got some more money from the government, and we added another 6 resources recently. So we have something called the Workplace Implementation Guide, because one of the things that you know about knowledge transfer is that education alone doesn't work. So we came up with a nifty 10 steps to implementation, and it takes you pretty well through, you know, if you've never done anything before in palliative care, you can start here, and it's about, you know, getting your working party together, so that multidisciplinary team, making sure that you have a policy and procedure for the things that you're going to be doing, how you're going to set up your framework, who's going to do what, and a whole range of educational stuff. We have a training support guide, which is where we walk you through all of the educational resources in the pack. Who should you use them for? How should you use them? You know, short sessions, whether they're for care workers or for RNs. There's a guide to pharmacological management of terminal symptoms. So that's really nutting it down to what drugs do you give in the last couple of days of life, and that's linked to the end-of-life care pathway. Therapeutic guidelines, as I said, resident and family resources, bereavement support booklets. There's a whole list there, and I'm going to go through each of them just very quickly, just to give a snapshot. So as I said, the workplace implementation guide is this 10 steps of the how to do, and this has been incredibly well received by the staff that we've been working with. So the training support guide really is the adult learning principles and how to use this. The pharmacological guide focuses on nausea, vomiting, pain, respiratory distress, restlessness and agitation. And it was really hard. We got this endorsed by the Australian New Zealand Society of Palliative Medicine, it's like herding cats, to try and get them to agree on, I think it's 8 drugs that we'll use across Australia that everybody will agree on. I don't know what it's like here, but everybody has their own local rules. You know. Resident and family resources, we have some brochures about grief, understanding the dying process, and an invitation to come to the family case conference, because the families actually didn't know what we meant by family case conference or palliative care case conference. Neither did the staff when we started either. And that gives them an opportunity to write down the wishes that they want discussed or the concerns that they want discussed at the case conference. They also get to mark on a rating scale from 0 to 10 how concerned or worried are they about those issues. And the analysis that we did as part of the pilot project, most people rated 7 or 8 out of 10, which means they're pretty worried and pretty concerned when they come to the case conference and they've got lots of things to discuss. There's bereavement support booklets for the staff, recognising that staff do grieve and how important that is, and setting up some ways that you can assist staff in dealing with that. There's 3 learning modules, and these are sort of the backbone of that framework. So the first one is really a sort of a guide for managers. That covers a lot of the things that probably are less relevant to you, in that it's our accreditation standards, it's our funding sort of model, but it does have things about evidence translation and practice in it. The real workhorses are Module 2 and 3. Module 2 is the key processes, advanced care planning, palliative care case conferences, and the end-of-life care plan or pathway. And Module 3 is the clinical care modules, pain, dyspnea, oral care, delirium, nutrition and hydration. You'll see there's no nausea and vomiting here. We don't have many people in Australia, and I'm sure you don't, that have cancer. The cancers are nausea and vomiting. Nausea and vomiting is a cancer thing, not a generally things in long-term care. We have 3 self-directed learning packages, one for care workers, one for nurses at the introductory level, which we recommend that all registered nurses or enrolled nurses, we call them enrolled nurses, they're the 2-year prepared nurses. And then we have an advanced one, which we would say your champions or link nurses, whatever you want to call them, should also do. They attract what we call CPD points, so they're for your registration. We have to do 20 hours a year, so we've added points to that. They have knowledge tests, and they're linked to training DVDs and case study. And these are the 2 DVDs that they're linked to. Suiting the Needs is a sort of a general introduction. It's 10 minutes long to a palliative approach, put together by Palliative Care Australia. And all on the same page we made as part of the project, and it's specifically how to conduct a palliative care case conference in long-term care. So as I said, they're linked to the self-directed learning packages, so you can either do it individually, you watch the DVD, you work through the package, or you can do it as a group and work. The third DVD that we have, which is just new, is specifically on the end-of-life care pathway, because we recognise that that was still an area where people needed a fair bit of support. So we have some brochures, a workbook and a DVD as part of. And the thing that's probably the most success, and I didn't bring it with me because this whole kit weighs about 8 kilos, is the flip charts. And the flip charts are an A3 setup, whereby you see on the, if you're the audience, you see visually a picture and some words, but if I'm the facilitator, on the back I have some prompts about what to say. We originally did PowerPoints for the facilities that we were working with, and then we discovered that nobody's got a data projector. So that wasn't particularly successful. The flip charts, designed for 10-minute education sessions, they're geared towards care workers. This one's about what's palliative care, sort of the framework, some self-care, cultural issues, and then, that's the visual of it. And then there's ones on clinical assessments, again, those 5 clinical things that we think are important. So that's the sort of setup, and as I said, people love these. So that's the toolkit. So as you can see, it's pretty well got most things in it that that you probably need to implement a palliative approach. At the moment, we have $2 million to roll this out across 1,000 facilities in Australia, and so we've got 2,700 facilities in Australia. So we've got money to reach 1,000 facilities. We've done about 13 or 14 workshops, I think. We've covered 550 facilities across Australia. So coming to Canada is a long trip, but I do a lot of travelling in Australia as well. And as part of that follow-up, we also do online webinars. They have contact with the nurse practitioner for specifically clinical issues. We have clinical newsletters. And we're doing online audits, which is at the resident level, which is after death audits, and organisationally, a bit like Mary Lou's organisational audit. But we're trying to do that online across the country and get people to sign up, and you get your own report. It's all confidential. You don't see anybody else's report. I see everybody's report, and what we're trying to do then is benchmark across the country with those, and people use those as their quality activities. So we're just doing that at the moment. So, and the next bucket of money that we're fortunate, this all runs, the $2 million runs out at the end of the year, and I'm fortunate to be part of another project where the government has given us $15 million, and we will actually cover the rest of the facilities in Australia, and we'll also be doing advanced care planning in a more detailed way, and we'll be setting up a 24-hour hotline for nurses and GPs to get advice on advanced care planning as well as palliative care. So if you're in a nursing home after hours and you have no idea what to do, you can ring a 24-hour hotline and you will get advice on what to do, and then you'll also get plugged into your local service where there is one available. So what can you take from this? The toolkit is underpinned by the international evidence. So some of the evidence is Australia, a lot of it's from the US. So it is an Australian toolkit, but it's not just based on the Australian evidence. The 3 key processes, advanced care planning, palliative care case conferencing, and the end-of-life care pathway, can be used anywhere. And the case conferences have been trialled as part of Mary Lou's project quite successfully here. The symptom assessment and management, you might have to tweak because you have some different drugs and perhaps some different assessment tools. But you can see how we've set it up, and perhaps, develop your own based on that. And I think family issues are universal, but again, you might have some cultural specific modifications that would be. So we have an expression in Australia which is have a go. So have a look, have a go. That's the project website. Happy to be contacted by anybody if you've got any questions. But please look at the resources. The DVDs are online, so you just press the play button, and please feel free to download them, print them, disseminate them. There's no charge at all for that. Thank you.